Can we start, Soria? Assalamu alaikum wa rahmatullah. Good evening, dear colleagues and friends. Welcome back to MIOM Academy activity, the Zoom meeting. Already we are now 3 months away from you. During that period of time, we have the conference, then we have another conference in UAE. So we keep it till we start the new year. So welcome back to our activity. And today we are having, and we will start with one of the, we can say, biggest area and very important area, and with very eminent speaker today and well-known figures. And I'm proud to be with them today in this meeting. Before we start, I would like just to introduce our speaker, Dr. Osama Jledi. He's a consultant ophthalmologist at Moorfield Eye Hospital, Dubai, specialized in cornea, cataract, and refractive vision. He is and correction surgery. He's adjunct clinical associate professor of ophthalmology at Mohammed bin Rashid University of Medicine and Health Science, Dubai. Our next speaker, it will be also one of the speakers is Professor Osama Shalabi. He is a cataract and refractive consultant. He is Faculty of Medicine in Tanta University, Egypt. We apologize, Dr. Ahmadi will not be able to join us. Professor Dr. Mahmoud Ismail is a consultant ophthalmologist specialized in cataract and refractive surgery, head of Al-Azhar Hospital, Cairo, I think head of ophthalmology department, Al-Azhar Hospital, Cairo, Egypt, and he is the president of Egyptian Ophthalmic Society. And also I'm proud to have my dear friends, Dr. Krishna. He's a consultant ophthalmologist specialized in cataract and refractive surgery, Prasad Natralaya, Odubi, president of KOS in India. And today the topic that will be deal with today, the first talk, it will be by Dr. Osama Jledi. He will give a talk about the role of Zedra in management of dry eye. Then we will have a discussion. Then we'll go to the second part of this meeting. We will talk about the ocular surface disease related to dry eye and other disease affecting the cataract or refractive or whatsoever. And we will have Dr. Mahmoud, Dr. Krishna, and Dr. Osama, and Dr. also Osama. They will give a talk about these topics. So we'll start now with, before we start, can you show me, Soria, our advertisement for the MIOM conference? Not this one. Okay. Anyway, there is another one. So our conference for the next year, which will be the 6th MIOM conference, and it will be the first ocular trauma in the region. So this is the first conference related or tackling the ocular trauma as one special day, and it will be a foundation. It is a foundation that we will have one day, and it will be the first ocular trauma in the Middle East. And we will have the second Bresmina, and also the first artificial intelligence in the Middle East in the next year. It will be all in 3 days. That will be in Dubai from 3rd to 5th of October. For those that are going to attend this meeting, we are encouraging the people to attend this one, and we will select from each month. We will have about the top 10 attendees in each month to be free registration for the 6th MIOM annual conference. And in the year, we will have another top attendance in the whole year. We'll get a free accommodations. So those they are willing to attend the conference, they are having the chance to be free register and also free accommodation. And now we will move to Dr. Osama, and we'll start with the first topic. Osama, the mic with you, please. Stop share.
Good evening, everyone. Thank you for Dr. Mohammed for the invitation, and MIOM for this nice gathering with my colleagues and friends. And good evening, everyone. Yes, I will share my presentation. Is it full screen now?
Yes, Osama, you are on.
So basically, I'm going to talk about the role of inflammation, dry eye, and particular to Zedra, but it's the role of inflammation that's the main area. Since the definition of dry eye, which is 2007 and 17, in the definition itself, dry eye consider there's some element of ocular surface inflammation. So it's a part of the dry eye disease itself, although it's multifactorial as we know, but dry eye still play an important role for the etiology of dry eye. And always we know there's vicious cycle whereas the tear film stability cause hypersmolarity, apoptosis, that's creating inflammation, release of cytokines, and that will more loss of goblet cell. Its instability more will causing more dry eye. The same things apply to the meibomian gland dysfunction. Bacterial flora releasing toxins and the enzymes cause less inflammation. Inflammation also cause lipid changes, more instability, and the same thing. So both of them like versus cycle, and really inflammation play an important role and very important to treat the inflammation when we wanted to control dry, especially in a moderate stage. And it can be dry can be caused by different causes from ocular surface, preservative, environment, viral, refractive surgery and cataract, which we're going to talk about it later on, autoimmune disease and hormones. That's all integrated all together can relate to dry eye. Clinically, when we had a patient with the dry eye, usually we don't see the typical sign of what we're looking for, inflammation in general body. So there's no redness, swelling, and pain, same like we're looking for inflammation. So it's a lower level inflammation. When you had the patient for dry eye, usually when we check the patient, we're looking for tear breakup time, Shermer test, tear osmolarity, or we can use mammography. All will help us to differentiate it. Is it this evaporative dry eye? Is it aqueous? Although many of our patients are mixed, but it doesn't tell us clinically how much this is a clinical significant inflammation or not. However, for fluorescein stain in the conjunctiva and cornea, if it's moderate to significant, it is shown the study that it's correlated directly with inflammation, and most people had, if you do MMB9, for example, you find it positive. The same things if people had osmolarity, if you have osmolarity test and osmolarity higher than 316, usually these people had moderate to severe dry. Inflammation in the dry disease is like there's the afferent effect, where the stress in the ocular surface releases pro-inflammatory. There's a ABC presented cell migrate to the lymphocyte. Lymphocytes producing the cytokine and the T helper for 17 and 1 and mix it and migrate to the ocular surface and releasing the what you call pro-inflammatory cytokines and cause the inflammation. So measurement inflammation in the tear will help us to assess the inflammation. One test we do nowadays, what we call MMB9, matrix metalloproteinase 9, which is the ideal biomarker we use it nowadays to assess for inflammation. It's very easy kit. We do it in the OPD clinic, and we use it Inflammidry. It's very fast, easy way to measure, but the disadvantage of it really doesn't quantify the inflammation. So it gives you positive or negative and doesn't identify the cause, but it has very high association with the dry eye survey score. Someone had very high score, usually they are positive if there's fluorescent test and tear breakup time. So it's very good way to test the inflammation in people who have dry eye, and when you don't know how much significant dry eye. So that's very good test to help us. So inflammation treatment dry eyes is, we know it for a long time now. We're using different modality to treat inflammation for dry eye, corticosteroid, cyclosporine, tacrolimus, lafitegravir, or doxycycline and azithromycin, and we're talking about one by one. Corticosteroid, as you know, it works on all steps in inflammation cascade, is very potent anti-inflammatory. It's reducing the inflammation at all level. It has very fast effect, or almost immediate. But usually when we use it, we need to use it for a very short period. Usually I use it like weaker steroid, FML or Lotamax for like a couple of weeks. And you need to warn the patient of the side effect, which we all know about it, cataract and glaucoma for long use. Cyclosporine, which is we use it for almost more than 20 years, is anti-inflammatory immune modulator. It's an anti-apoptotic. The mechanism of action inhibit T cell mediated inflammation by inhibited interleukin-2 activation. So it's inhibit activation in the lymphocytes. And that's the effect. That's why it take a bit longer, because it doesn't stop the active T lymphocyte. Tacrolimus, also the same mechanism like cyclosporine, but is even more potent. But the problem with tacrolimus is it's more irritated to the ocular surface. Laphitagraph with Zitra, which is now we're using, we are lucky here, we use almost for 3 years. We are the third country in the world after America and Canada. And this is just to show a video about how is the mechanism of laphitagraph with Zitra, how it works.
Lipidograph inhibits the interaction of LFA1 with ICAM. In vitro, lipidograph has been shown to inhibit T-cell adhesion to ICAM1, immunological synapse formation, and release of pro-inflammatory cytokines. These preclinical findings support lipidograph's mechanism against T-cell mediated inflammation. In vitro studies estimate that once activated, T-cells can live up to 164 days or up to 5.5 months. Lipidographs can act on circulating T-cells, both newly recruited and previously activated, by blocking a key step in T-cell mediated inflammation in dry eye disease. Inflammation is part of the vicious cycle of dry eye disease. Lipidographs disrupts the self-perpetuating process of inflammation by blocking LFA1 and ICAM1 binding in the immunopathogenesis of dry eye disease.
Specifically designed to target a source of inflammation in dry eye disease, it is thought that Xiidra targets both inactive and active T cells, thereby helping to disrupt the continuing cycle of inflammation. Xiidra blocks LFA1 on inactive T cells from binding with overexpressed ICAM1 on the ocular surface and may prevent formation of a specialized cell junction between specific immune cells, which may inhibit T cell activation. Xiidra is thought to inhibit migration of activated T cells to the ocular surface and may reduce cytokine release. Xiidra is a first-in-class prescription therapy thought to target both active and inactive T cells in order to interrupt the chronic cycle of inflammation.
So basically, it's FDA approval, and as in the video demonstrate the mechanism, it's prevent interaction binding of the LFA on the ICAM, and because of that, it's really have faster effect. It take about a week to 2 weeks to have effect, and that's affecting the all level at the cell tissue and the vascular endothelium tissue. So it's a very powerful way to reduce the inflammation for dry eye. The other modality, we use doxycycline and tetracycline for a long time for treat meibomian gland dysfunction. It has antibiotic effect. It's inhibit bacterial lipase in release, and also it has anti-inflammatory. Although nowadays we shifted more of us, we move using azithromycin more often now because it's the advantage has prolonged effect. So shorter course, like 500 milligram once a day for 3 days, or using topical for 3 days, but it lasts for like 2 to 3 weeks. You don't want about sensitivity, the photosensitivity. You don't want about the risk of pregnancy. So we shifted more to use azithromycin more than doxycycline. In general, anti-inflammatory therapy like corticosteroid, laphitagraph, cyclosporine, it works in different bad way, and it can be also combined together for in some patients. The used guideline to treat dry eye according to the severity, for step 1, we're using it just lubricant to educate the patient about using the artificial tear also. But from step 2 onward, they recommended to use anti-inflammatory. Same things apply with their guideline 2017 also. They recommended if you have step 2, you need to think about inflammation and need to consider sort of anti-inflammatory medication on top of the lubricant, avoid the preservative, which we do. Zidaris, which is another group which is looking for dysfunctional tear syndrome, they look in is very good guideline they have to treat the dry eye, basic in not in the severity, but also the classified. Is it aqueous deficiency? Is it the blepharitis, meibomian gland, globulate deficiency or exposure? And the three first category, when is more than just if the lubricant is not enough, then recommended to use anti-inflammatory. One of them, Lafitagraph, as a recommendation. Many people ask me, because we had Zidra almost like 3 years now, they ask me when you start using Zidra. Usually I use it for stage 2 or any dry disease which not improving with just lubricant and patient education. Same indication like what we're using for cyclosporine. Usually for moderate and conjunctival stain or corneal stain, in the moderate stage, if it osmolarity very high, if I did MBB9 and found it's positive, then I know this is significant inflammation and better to use anti-inflammatory medication for moderate MGD and the patient who cannot tolerate it, cyclosporine. As I mentioned, we use it almost for 3 years. We're lucky to have it and covered many of our insurance. Majority of my patients, they have it happy, but some of them, they complain of stinging, which and irritation. And people, sometimes when you use the drops, they don't have a nice taste, some of them. So sometimes I ask them to just press in the punctums to reduce the feeling of taste. Regarding, this is one of my patients who had severe meibomian gland dysfunction. You can see his meibomian gland is very, very thick, like toothpaste. This is expressing with the forceps. This is just the presentation to me. He had a lot of SBK in the fluorescent, and I started him with Zidra. And after a month, it's really a big improvement in the quality and quantity of the meibomian gland. And this is the picture 7 months. He's really much, much better. This is another patient, you can right eye and the left eye. This is before Zidra, and this is after 6 months. So the quality of the tear meibomian gland secretion and the patient's symptom is improving a lot. Remember, when we treat the eye, the goal of the treatment, we always need to treat the trigger factor, whatever, if it's there. We need to treat the inflammation, whatever the reason for the inflammation. And remember, this is a chronic disease. Always you need to remember that you need to use the medication for long. You usually give a 3-month course and aim it to use it for a year. So always very important to educate the patient. This is a chronic. We need to use a longer, a better treatment. Conclusion, inflammation play a very important key role in dry disease. It's important to treat inflammation in dry disease and to stop the vicious cycle and prevented the dry to get worse, because as we know, if we leave the dry without good treatment, it will be more damage to the eyes, and that's difficult to reverse it back. Artificial tears still essential and one of the mainstay, and we're lucky there's too many artificial tear drops available. Very important to really try to avoid preservative-free as much as possible. Steroids is very important. Anti-inflammatory is very good to use temporary, but very important to educate the patient not to use for a long time because of the side effect. Zidra is a safe, effective anti-inflammatory to treat dry disease and MGD. Patient education and compliance with the treatment is very important. Really, always when you see the patient for dry, you need to sit with him a reasonable time, explain about the disease, how to change the environment, things to control the dryness. That will help you in the patient compliance and also the patient, the follow-up with the patient and better the result to the patient. Remember, there's different anti-inflammatory can have different way of control the disease. Majority of us, we're using separately items like cyclosporine or Zydra. Some people use combination, but there's the problem is the cost and insurance covered. And thank you very much.
Thank you very much, Dr. Osama, for this comprehensive and very nice presentation as usual. Maybe we can take a few questions. If there is any question from our colleagues, attendees, they can send us in the chat. So question we can, and if someone want also to be with us live, he can just raise the hand. Also, we can take him live to discuss anything with any of the speakers. We can take first here. We have Dr. Krishna. You want to have a question?
Yeah, I just wanted to ask Dr. Osama regarding, see, I just saw your slide, especially when you're pressing with the forceps, I could able to see a lot of secretions are coming out of the lid margin. So I could able to see, in fact, unfortunately, still Zidra is not available in India. We still depend upon cyclosporine and other modalities of treatment. So talking about what I do, apart from the treatment, actually, we always even do something called highlight treatment, or we also combined with the sometime with the lipid flow, depending upon what the machine you are having. Do you try this kind of, like when you are having such a severe mebobonitis, do you try with the lipid flow or eyelid treatment and combine with these drugs so that the action will be little faster?
Yeah, I use, but the problem is the LipoFlow doesn't cover by insurance. So it cost, for us, it cost almost 1,500 dollar. So it's a bit expensive. Zidra, we are lucky it's covered by insurance, okay? So I educate the patient about to do warm compressor massaging, and I do it sometimes manually myself, initial stage, but definitely it will help. But the problem is the cost.
Yeah, thank you.
Any comment or question, Dr. Mahmoud or Dr. Osama?
If you allow me, I would like to congratulate Dr. Osama Jalidi for his excellent and comprehensive presentation. And I would like to know if do you use azithromycin? We are very commonly here using azithromycin topically. We have it on shelf when it's very cheap in Egypt, thanks God. And actually, I found, as you said, very good outcomes from the azithromycin, even more than the doxycycline. I stopped doxycycline. I don't give any doxycycline anymore. I have been a number of years giving them, and I'm really not convinced with them. And I see the azithromycin topically, especially topical azithromycin, as a very good option. What do you think, Osama?
Yeah, definitely, it's very effective. Although sometimes they don't like it, stinging too much. So it's I just reassure them it's 3 days course, and it's different regime. I use it sometimes twice a day for 3 days. Sometimes I use it once for longer. But it really is very powerful, yes. But sometimes if especially people with rosacea, another I use azithromycin tablet.
Yeah, as an adjuvant, but
Yes.
actually, I'm not sure that I was not lucky with the doxycycline actually, and
no, azithromycin means tablet.
yeah, azithromycin tablet and topical for me is giving much better. Maybe.
Yeah, I don't
maybe
use the doxy. Yeah, I don't use doxy much at all. I use azithromycin either drops or sometimes I use a tablet, azithromycin tablet.
Yes, exactly. Yes, and maybe because we have endemic trachoma here, Osama, in Egypt. That's why maybe because it's the response excellent to the trachoma. Also, do you have the preparation of the tacrolimus, or you prepare it by yourself, or it's on shelf?
Okay, tacrolimus. I really were lucky. India is not far from us. India, they have a lot of tacrolimus ointment. We had the one for the skin, but I asked the patient to get it from India. Really, they have a lot of company. Almost like I know there's 3 companies in India. I'm sure there's more. They have ready-made one. I found it very easy to ask them to get it and get it from there.
I think it's, let me be honest with you, Dr. Osama, we have a lot of people here preparing, a lot of pharmacies, and they have license for preparation. They are licensed pharmacies for preparation of anything, any drug you want, they can prepare it for you. But let us be honest, it cannot be as professional as the pharmaceutical companies. So I think it's better to import it from India until we have it here in local. Thank you, Osama, for the nice presentation.
Thanks.
Dr. Osama Shalabi, إذا حاب any comment?
Yes. First, I have comment on compounding pharmacies. I think these compounding products usually are irritant to the ocular surface, and I don't use it in my practice actually. For Dr. Osama, I would like to ask you, in such a severe case you have shown us, it is you start the Ocular from the start, or you just expression and heat therapy and massage and other corticosteroid, topical azithromycin, and other measures for neuronal gland dysfunction, and later on you may use Ocular, or you use it from the start as a first line of treatment in such a case.
Yeah, but it's usually most of my patients like that one is not the first. He have been in different places, and it's not the when it's moderate to severe. I started straight away. It take about 2 weeks to have effect. I usually give a steroid for 2 weeks with Zidra at the same time, so at least the steroid will suppress the inflammation quicker, and the Zidra to keep controlling the inflammation without the side effect of steroid.
Okay, you have the luck, you have the etc. covered by insurance.
Yeah.
Yeah. Okay.
Just one small last question. Sorry to bother you, just with the permission of Dr. Mohammed Amri.
Yes,
Yeah,
please go ahead. Yeah.
yeah. Just a couple of questions. One is actually uh, after this course of whether it is a doxycycline or azithromycin. So I just wanted to ask Dr. Osama that once this antibiotic course is over, do you believe in something? A lot of institute they put something tablets called Macuberry tablets. I think whether you are aware of that or not. In India, we use this Macuberry capsules for a period of 3 months, oral capsule that gives a very good results for ocular surface. And second one of my friend hospital in Bangalore, Narayan Nethrale, I think all might be knowing, is a very close friend of mine, Dr. Rohit Shetty. They had come up with one unique kit where they can take the tear fluid and find out the different enzymes. Like you are showing about only MMP kit and all other the other parts we cannot diagnose. Suppose once that kit comes, once if you take out your tear fluid, put it in that kit, then find out which is the abnormal enzyme, then I think our job is going to be much easier.
Definitely, that kit will help them to measure different anti-inflammatory. But to be frankly, we don't have much option other than the main steroid, which block all inflammation, and we have cyclosporine and Zidra at this stage. But I'm sure maybe this different modality molecular available in future will have different way to help us to choose which one. So definitely yes, but it's still a bit early because I think that kit will help a lot of other diseases, not only the dry eye, but a lot of other diseases which
So
they have some inflammatory.
what about Macuberry? Do you use Macuberry capsules in UAE?
No, we don't have. No, we don't have.
Okay, thank you.
Okay, Sama, I have several questions by some of their colleagues from the attendees. So we will go on that very fast. About tacrolimus, what is the concentration first, the eye, and for the how long?
So basically, tacrolimus, as I mentioned, I use the one from India really, which is 0.03 is ointment. I use it at night time, but I usually because it's also burning a bit, so I give it at night time once a day. Some people use the drops. We don't have a drops for me, and people prepare drops from the tablet. But here is a bit tricky. We don't have easy to license to do the pharma itself. So it's a bit tricky, so I use the ready one. I usually use ointment, but I usually combine with the other anti-inflammatory. As I mentioned, either cyclosporine or Zidra, and then add tacrolimus, but usually not more for dry, more of Vernal, Steven Johnson, Bimfigol. Something is more higher inflammation more than dry.
Okay. Also, in very short, Osama, very, very short. What for the are there any contraindication for Zidra?
Allergy.
Only allergy. Okay.
If
There is someone asking what is
cost. That's cost.
He's asking what is the cost of Zidra?
770 dirhams. So it's almost
I think for 2 months.
$230.
For 2 months.
Yes, for not 2 months. It's for a month, but there's a 60 pieces. So if you keep the same one, you could. That's what I mean. So if the same like Restates also 330 for one box. You need 2 boxes if you keep the same. You throw it away.
Okay, there is another question. So can we keep it till the end? So we will come back to
No problem.
Osama.
Yeah, that's fine. Yeah, no.
Or if you want, you can go through it, please, because there is a lot and we are
I
running
think it's
behind.
better to go with the other speaker and then we can go back and join the question together.
Yes, that's what I'm trying to say. Okay, so now we will move to my dearest and Dr. Mahmoud Ismail, and he will give a presentation about evaluation of different laser vision correction technique on ocular surface. Dr. Mahmoud, please. Dr. Mahmoud, can you, because you are mute, can you unmute yourself?
I'm sorry. I would like to thank you, Dr. Muhammad Al-Amari. You are gathering us always, and Miom Academy is getting us together to share and evaluate our science more and more efficient. Actually, to evaluate our different laser correction techniques on ocular surface, we all know by now that we have some kind of contraindication while we are treating our patients. We all know that the tears are not only one layer, there are 3 layers. The most valuable one of them is the oily layer that the meibomian gland secretes. We are getting more dry and we are getting more hot by the weather and also the eyes. This is a real picture from Alicante, Spain. This used to be a very big lake. We used to go there and swim 30 years ago. And now, as you can see, it's completely dry. So our eyes will respond the same. We are getting more dry eyes. But this is not only the problem. The problem that we have 2 entities in the classification that we have to discuss together today. One of them, and this is by TIFOS, that LASIK is one of the very high causes of dry eye nowadays. Also, the poor blinking. And the poor blinking comes from the idea of screen time. Why screen time? I will explain to you the more screen time in the next slide. What happened in the last 25 years? This is how it looked, the television on the finish at 12 o'clock, and then comes the satellite that everybody had in his home, then the laptop, and we returned back to work in home, so we had more screen time, and finally, and the most dangerous, we added a small screen to our life, which is the smartphones that we are using beside the satellite and beside the laptop that we had. So we are abusing our screen time available. This is the case that one of the colleagues referred to me, and as you can see, he did LASIK and he is on all types of lubricants, and he had sessions of dry eye treatment and expressions, but still the patient is complaining. And as you can see, keratopathy started in the edges of the laser and the lower part of the flap, and still there is very high incidence of dry eye in post-LASIK patient. So at the beginning, it was it was actually not a good candidate for such technique. The visual fluctuation occurs with these kind of patients. So you can put them any kind of eye drops and he suddenly can see very well. So this is you have to restore his tear film layer. Also in Egypt, at least, we have very poor compliance on treatment for a long time. As you can say that the patient, you have to go on putting this eye drops for life 5 times per day, he is not compliant. And he comes complaining that the treatment is not efficient, not because he is not compliant. A number of years ago, we did a study on meibomian gland and secretion of tears with my colleagues here, and we presented in the ESCAS, and we are lucky to discuss it with you today. We took 2 kind of devices, 2 different systems, 2 different way of measuring, and we analyzed the tear film and the breakout time with them, and how much the degree of break time with these 2 machines and 2 different technologies. And we refer to the meibomian scale, the famous meibomian scale, and the efficiency of the dropout to describe and to address the degree of pathology that happened to the patients. And as we all know, the corneal nerves are cut when you do LASIK, and the corneal nerves comes from the ophthalmic branch of the trigeminal. Once we did the study, we found that the worst patients were the LASIK patients, and this is very obvious, and you all know about it. The next comes the flem to flap together with the smile lenticule, not big difference. And the best to come is the PRK. And it took almost 1 year for all of such techniques to approach each other, but still the PRK had the better results even after 1 year, not only in the early post-operative. So if we are tending to remove the epithelium, how can we should remove it in the PRK? Okay, we will do PRK, as the English people have The British, the German Medical Council, as Osama have they addressed the PRK up to -8 diopter because it's the incidence of dry eye is less. But if you try to mechanically remove the epithelium, you might have the potential of injuring the bowman and subsequent keratitis, and the re-epithelialization doesn't come all together, so you are not monitoring really the patient, and of course it's more painful for the patient, and it's not comfortable at all, and the regeneration gets time. So some of our colleagues, they insist on putting alcohol, and this is a very good study by several authors published from Korea. They have demonstrated that the effect of alcohol goes on forever. It affects the integrity of the corneal epithelium and the subsequent inflammation, and it might be one of the precursors of ocular surface disease. So how about removing the epithelium by excimer laser? This is a very new idea. This is how it looks by laser, and this is how it looks if you remove it by manually or mechanically. So is it new? Actually not. Professor Aliou and myself, with Alberto Altora, 30 years ago, we published this article about how to remove the PRK with PRK, doing some kind of PTK. We calculated the average thickness of epithelium in cadaver eyes, and we have reached that if doing laser epithelium removal, it would be the recovery is much better. The pain, the inflammation, and subsequent complication of PRK is less. So why didn't, this is how it looked, this is 1993, and we had a very good citation in the first year by 33 citations, only the first year. And this was very rewarding, and it was published in the Journal of Refractive Surgery. So why didn't the laser epithelium remover succeeded to overcome all over these years? Simply because in 1993 and the early 1994, suddenly goes out the LASIK. It goes popular. So everybody abandoned the PRK itself. And everybody forgot about the PRK, and it was the wow effect of the LASIK, very temptative for all corneal surgeons to make refractive surgery and not to do PRK and stay for 1 week with the pain and the fluctuation of vision and some haze that happened at that time. Until Bosch and Lohm discovered that it can be removed and integrated in the system, and it's now all the machine they have transepithelial removal with PRK, faster and regular. It doesn't depend on the operator itself, and you are not touching the patient. Actually, you can do it without a speculum. In a case, some cases, if the patient is very tense, it helps also in irregular corneas. Whenever you have a masking effect, you need a masking effect. You need to regularize the surface before applying the laser, the excimer laser on the surface to refract the patient, to take the opportunity or to refract the patient. Actually, this makes removing the epithelium by excimer laser, it's as if you have put a masking effect and equalizing the surface itself. So let me give you a small case, which is very interesting. It's a nice lady, which is well educated, operated by keratoplasty. She had a minor trauma, and she had a central opacity, and she was operated for penetrating keratoplasty in one of the Gulf areas. And then she moved with her husband to another Gulf area, and 3 years ago, she removed all the sutures in the other city where she moved. But the patient came to me a few months ago complaining that her vision in this eye is very poor. I tried and tried and tried to refract her. No way. I did all my tricks in refraction. And finally, I went to a refraction which is not very suitable and very, actually not very sure that she has. Even with stenopic pinhole, stenopic slit, I'm sorry, with the stenopic, you only can get the axis of the refraction. However, with pinhole, she went up to 0.5. So it was irrefractable, and this is actually is a terminology that it's not an English terminology. Just we just called her like this. So what to do with her? We sit down with the patient. We told her we just instead she was advised to repeat the penetrating keratoplasty once again. So I told her, why not we do a compromised refraction in order to get a refractable eye. An eye can be refracted by glasses. So after doing a lot of trial and a lot of chair time with her, we decided to do her a -5, -2 diopters astigmatism in the same axis with the slit stenopic that we had with her. And this is how she looked in the surgery. She was a very cooperative patient, actually, as you can see, and she accepted the proposal of doing a surface ablation just to regularize the cornea and to improve her best corrected visual acuity with glasses. She was wearing glasses in the other eye, and she was not very, and she was looking for that. She cannot wear contact lenses. She was intolerant to any kind of rigid gas permanent contact lenses. So once we finished the surgery and with the regular regime with her, this is how she looked before surgery. As you can see, 10 diopter of astigmatism. And in spite of doing all the means in the whole world, I couldn't get her better than 0.1. So we decided to just to ablate -5 diopter and only 2 diopters of astigmatism. And surprisingly, she was very happy. In spite that the astigmatism that we have planned for her reduced only -2 diopter, because the central optical zone, as you can see, the pupil is more flat and more regular than before. And she had an uncorrected visual acuity of 0.5, but the patient was highly satisfied because the dry eye symptom disappeared, because the surface came more regular. And this is one of the reasons why we have to consider in some kind of patients of a regular surface, some kind of PTK of laser surfacing, just to improve the quality of the surface of the eye before managing the dryness itself. Once again, thank you very much. And to be concluded that sometimes all technique can serve in the recent days, as this kind of surgery, cataract surgery, that in the temple of Edfu have transmitted to the Andalus in southern Spain. This is the same instrument, as you can see. This is 3,500 years ago, and this is 850 years ago. And it's a painting in the Cordoba Museum in Al-Andalus. Once again, thank you, Dr. Amri, and thank all the colleagues for such nice meeting. And I would like to remind you that we have our annual Ophthalmological Society, Egyptian Ophthalmological Society, and it will be the 24th to 26th of April, and we would love to see you there. Thank you very much.
Thank you very much, Dr. Mahmoud, for this an excellent and comprehensive and very clear example for our aim today in relation of refractive with the ocular surface disease, especially the case that it show how it's make difference of her life from 0.1 to 0.5 and happy also and no complaint. If there is any comment from our colleagues here, and I think we will keep maybe the question till the end of the meeting. Usama or Dr. Usama Sharabi, Usama, Dr. Krishna.
Yeah, excellent presentation, Professor Mahmoud Ismail. It is really nice to see as you said that we started with the PTK, then PRK, then now we are doing like a one-step trans PRK. In fact, most of our in India have got the SWIND latest machine, SWIND amarysis. It does the basically it take out the first stroma, then followed by epithelium. You know that it is a single step procedure. So, of course, probably as far as the PRK is concerned, there is no financial interest. I do have got a MEL 90 system with me, but this SWIND machine, particularly, especially for PRK, does a fantastic job. What is your opinion on this, Ismail?
Yes, I have Schwinn the machine in one of the facility that I visit couple of times every month, and actually one of the very good and standardized machine, the Schwind. Actually, it's very nice in such technique. But the idea of making trans EP was captured from the literature by Bosch and Lomb. It salvaged it first, but it seems that Schwind is giving it a very more intensive treatment and very compromised, and I'm not compromised, actually more comprehensive nomogram, which is actually giving a very good results also.
What is your cutoff value for doing PRK? What is the cutoff refractory error for your PRK? Because I do a lot of smile, but you had shown in your graph telling that definitely, I do agree with that PRK is better than smile. But again, depending upon the how much is the refractory error of the patient. What is your cutoff in your case? What is the cutoff power?
Yes, so this is a very good question, my dear friend. And we had a lot of debates here in Egypt about the PRK. How is the limit? Should we go up to -8? And it was I was the president of the Egyptian Society until 31st of December, and we had a special session in one of our meetings just to debate this kind of issue between smile femtolasic and the PRK. And we agreed almost, because some people are not in with us, up to -6 diopters. Some people did still do to up to -8, guided by the British declaration. And I don't blame them, because there is a lot of studies about of having PRK up to -8. However, myself and the most of our society, I think we're up to -6 diopters is okay.
Okay. Thank you.
Thank you,
Okay,
sir.
any further question or comment before we move to the next presentation?
No, thank you, Dr. Professor Mahmoud. It's very nice, and really that's the trans PRK, or I use the icon now. It's Streamlight. There's different names in one. So it's just this laser remove the epithelium is good, but I think it's really the only thing caution about some bit if someone retreatment, if the epithelium maybe like enhancement, you need to make sure better to measure the, nowadays we had the epithelium mapping, so it's really very useful now. We check the epithelium, so use the epithelium mapping, and that will help you to avoid the cases where you shouldn't do trans BRK for this particular patient.
Definitely, Osama.
Okay,
I
thank
agree
you,
with.
Dr. Mahmoud. Thanks a lot, all. We can move now to my dear friends, Dr. Krishna. Kudlu, he will give a talk about evaluation of ocular surface before cataract surgery. Dr. Krishna.
Can you see my presentation?
Yes, please. Can you put it on the
Yeah.
slideshow?
Yeah.
Great.
Thank you so much, my dear friend, my brother Mohammad Amri, for this wonderful opportunity. What a pleasure to be part of such an association who is really making a great job as far as the science is concerned. So my talk is today evaluation of ocular surface before cataract surgery. So I don't have any financial interest for this particular talk. So I think when you talk about healthy ocular surface, most of the patients are satisfied, those who come to us. The patient dissatisfaction following cataract surgery most of the time is going to be the poor ocular surface. Of course, ocular surface abnormalities can be quite common among the elderly population, as we all know that. of course, it affects the refractive outcomes, and also that may lead to some of the post-operative complications. So coming to the what might be the reason. So when you think about, okay, I'll just go to, if you do a patient with a ocular surface disorder, cataract surgery, what will happen? There will be definitely repeated drying, there will be irrigation, then followed by you'll be installing eye drops. Sometimes the surgery might be more, and sometimes you may have phototoxicity. Sometimes some manipulation during the surgery, like speculum. When you're putting the speculum, you may have like some problem, or sometimes when you're opening the flax incision or flax suction ring also cause a problem. Along with that, you may have damage to the nerve layer also, and it all gives rise to the trauma to the corneal epithelium, trauma to the conjunctival epithelium, damage to the goblet cell that leads to the dry eye. So I was just going through a lot of literatures about if you directly go ahead, suppose the patient come on the particular same day without checking the dry eyes, you go ahead with the cataract surgery. So I was just going this one interesting article from Hiroka et al. That is the influence of dry eye disease on the measurement, repeatability on corneal curvature, radius, and axial length in patient with cataract. What actually he proves that if you do the biometry, normally the patient with a very severe dry eye, the chances of having a poor repeatability is very high, and also you may have a false values. So coming to the how can we really tackle this dry eye before cataract surgery, I am going to make in 4 different heading. One is symptoms, examination, imaging, and treatment. So let me come to the symptoms. I think we all know that. I think in online everybody gets this ocular surface disease index. I keep it in my clinic. This is a purely questionnaire. Suppose if the score is between 0 to 12, that means it's normal OSDI. If it is between 13 to 22, it is mild. It is 23 to 32, it is moderate. And more than 33, I consider this one as a severe one. So coming to the examination, I think as Professor Osama was telling about the beautiful case of a meibomianitis, slit lamp examination is utmost important. Always look at the lid margin properly. See for any abnormalities, whether the patient is having any foamy discharge is very important. Look for any telangiectasia and look for any other symptoms of obvious dryness. So once the slit lamp examination over, these are the two very simplest of the test I think most of have to do. One is Shermer's. You can do either Shermer's 1 and 2. I prefer to do Shermer's 1. If it is less than 10 mm in 5 minutes or tear breakup time less than 10 seconds, that means the patient is already having dry eye. So again, I was just going through some of the literature, especially on evaluation of ocular surface after the cataract surgery. What it shows that if the patient is already have the ocular surface was affected after 1 month of the cataract surgery, that also if with the normal ocular surface, if the normal ocular surface after cataract surgery affected, that means if you check for a T-bud which has been definitely shorter, Shermer's 1 test and even corneal nerve density were decreased while the OSDI also been increased. But just imagine if patient is already having a severe dry eye, you go to the cataract surgery on the same day, you may land in a lot of problem. So coming to the imaging, I think Professor Mohammed and also Osama was mentioning about some of these very important equipment. I think this. I think I do tell in a lot of my friends. Some of them not affordable in India to buy this higher end equipment, but everybody will have a autorefractometer in their clinic. You can capture this mibography by even very simplest of the autorefractometer. But of course, all these equipment like me check, you can know whether the meibomian gland is fine or there are meibomian gland having some problem. So I was just going through one of the article actually from the Kochner from JCRS. What he said that the incidence of meibomian gland dysfunction was very high in patient presenting for cataract surgery. As I already told that these patients are quite old, so the incidence of probably the meibomian gland dysfunctions might be like a little bit high in this patient. So what will happen? There will be MGD, meibomian gland disease. There will be meibomian gland loss also that lead to ocular discomfort, suboptimal visual outcome. In the end, patient will come to you with an unhappy cataract patient. So this is one of the, I don't have any financial interest with this particular instrument, the eye trace aberrometer. All we have seen in the latest model of this eye trace, they have come with something called a tear film index, which is, I can say that it is an objective method to know in a one single test to know about the topo breakup time. And normally scale is between 0 to 10. If it is around 10, that means the patient is having a almost a good ocular surface. So I think this will make most of us job much easier to know what is going to be the tear film index. Now coming to the corneal epithelial thickness mapping for probably for corneal epithelium, is it required? Already the previous speakers, Osama also and the professor also told about this is very important. If you ask me, I think this corneal epithelial thickness is a surrogate marker for dry eye. So it will find out the irregular epithelium. If you have the patient with the irregular epithelium, you'll have a very poor healing and nerve degeneration, lead to ocular discomfort with a poor visual acuity, again go rise to the unhappy patient. So my imaging part is what there are a lot of equipment available to know this imaging. Just I was highlighting about couple of equipment which can really help you for your diagnosis. So coming to the treatment. So patient with cataract, okay, how before we have to treat this ocular surface, then only we have to go ahead with the cataract surgery and even the refractive surgery. So it is depending upon the symptomology and also on the examination. Whether it is asymptomatic, depending upon the TBUT or the OS, ocular surface disease index, whether it is again on the mild symptoms or severe symptoms, depending upon that you decide. Then coming to the imaging part, no gland loss. If the patient is having regular epithelium, tear film index, as Professor Osama said that you can just go ahead with the lubricating eye drop. If you think that, okay, there is around 25 to 50% gland loss, regular epithelium, tear film index around 5 to 8, you can go with the topical steroid cyclosporine with lubricating eye drops. Of course, in your country, you got Zidra also. So when you have got a more than 50% gland loss, irregular epithelium, tear film index less than 5, that means I always take them for a dry eye therapy. So different dry eye therapies are available in the market. So talking about the eye drops, always better to put always a preservative free eye drops. I think most of the companies nowadays opt for this kind of option. Always maintain the very good lid hygiene, very important. Once the treatment over, always reassess the ocular surface first, third, and sixth week. This is about the IPL lippy flow. We do lots in India. So I have got a highlight treatment in my place. Some of the center they do lippy flow depending upon how you do this one. Basically, it's a intense pulse light therapy, or some of the technology they show that it is a thermal pulse therapy that improves the gland outflow and also tear film stability, that gives a good healthy ocular surface for a better patient outcome. This is what we do in our center. So when normally, since I got highlight treatment, each treatment has got different modules. Some people tell that you do a single sitting, after 15 days you directly do the cataract surgery. But I always call them for 1 week apart, 3 sittings. Then normally, sometimes if the patient is very much eager to undergo cataract surgery, after 2 weeks, normally I take them for cataract surgery. So this is very important. So in the conclusion, always ocular surface disorder take away huge chunk of patient satisfaction. It can exist in the absence of even evident clinical signs. This is very important. Optimizing ocular surface is vital for enhancing post-op outcomes. Treatment should ideally begin in the pre-operative phase. I thank my brother again, Mohammad Amri, for this wonderful opportunity. Thank you, one and all, for kind listening. Thank you.
Thank you very much, Dr. Krishna, for this a very interesting and comprehensive. Really, I enjoy your presentation. Thanks a lot. You make it very simple and very easy and direct to the point. Thanks a lot. So is there any comment, Dr. Mahmoud, Dr. Usama, or questions to Dr. Krishna?
Yes, excellent presentation, Dr. Krishna. Actually, it's very comprehensive, I'm sorry, and it's very a good approach to the patient pre-operative. And I think pre-operative is much more important than post-operative. Anything we say to the patient in the pre-operative is scientific expectation. Anything we say to the patient in the post-operative, it's just justification to what we have done. So I like the diagram that he or his approach, and I would like to ask him, do you use the intensive pulsed light? We have it here in our facility, we have it, but you think in post-cataract surgery it is efficient as in post-refractive surgery patient in your hands?
Yeah. Post-refractive surgery and post-cataract surgery, normally I wait till a minimum of 1 month. Till 1 month, I never do this highlight treatment because there might be some problem. I did it for a couple of patients after 15 days. They're very, very unhappy. So normally I wait.
Yes.
So before the procedure, as I said that, I do it, then 2 sittings, then I take them for cataract surgery or refractive surgery after 2 weeks. Preferably 3 weeks, 3 sittings,
3
I
weeks.
like, then do the procedure, both cataract and refractive. That is the standard way. But still, a lot of my friends, they don't want to wait. They think that they may lose the patient. So they just do it within a couple of weeks so that
Yeah.
win-win situation for both of us. But ideally speaking, I think 3 weeks. But post-op, as you are told, after a 1 month, again, if the patient is very much symptomatic and all other important signs and all other investigation thing that still we require more sitting, then after 1 month of the cataract surgery or refractive surgery, I just continue with the highlight treatment.
Excellent. Thank you, doctor.
Dr. Osama Shalabi, you have any question or
Yes.
comment?
Yes, Dr. Krishna, very nice presentation. But do you have any way parameters to start pulse therapy and before? How can you decide it's 2 or 3 sessions before deciding going to surgery? Do you have any parameter to start this pulse therapy or?
Yes, sir. Actually, see, before the exactly some 2 to 3 years before, we just used to do a Shermer's and we used to go ahead with the cataract surgery. Then now we started doing a comprehensive dry eye clinic in my hospital. We just rule out everything. Like first, as Professor Mohammed Ismail showed about the gold standard of how you grade this in, especially in me check. Me check, we grade, then followed by T-Butt and other test Shermer's one. If I think that, okay, all these graphs showing a very severe dry eye, very severe meibomian gland disease. One, this side, Shermer's also shows that less than 10, less than 6 or 7, then I immediately decide that I have to go ahead with the intense pulse therapy for that patient. Those patients, I start them, I tell them that you have to wait for 3 weeks. I cannot do anything. First, you undergo this treatment, then followed by a cataract surgery. Always my patients are very happy.
But intense pulse therapy is specific for meibomian gland dysfunction. If the
Yeah.
patient has other alterations like unstable tear film, in spite of having,
Yeah.
do you
So,
also use intense pulse therapy?
yeah, no, sir. See, intense pulse therapy only for the meibomian dysfunction, gland dysfunction. If you don't have the meibomian gland dysfunction, still the patient having dry eye, I start them on the cyclosporine. I had initially to start with this presentation, I told we have got a one wonderful drug called Sequa, which is normally acts within 14 days of the installation. So I start them on Sequa. Then after 14 days, I just cross-check again with the how much is going to the T-Butt and also the Shermer's. Then if I'm happy, I think after 3 weeks, after Sequa, I do the cataract surgery, but I will not stop the Sequa. I'll just stop for a after the cataract surgery. I do continue this cyclosporine along with the steroids.
Okay, very nice. Thank you.
I think we have one raised hand. Can we, Dr. Muhammad, if you can open for him, Surya. Dr. Muhammad, you are with us? Dr. Muhammad, Samra?
Unmuted.
You are mute or unmute? Or maybe by mistake, he just
Yeah. Okay.
raised the hand. Okay. So we can, is there any comment, Dr. Osama Jalidi, before we move to the next
No,
talk?
that's very good talk. And this you highlighted that's important to check for ocular surface disease before cataract, especially nowadays with this premium lenses. And really that's very crucial to diagnose dry eye, because if you don't diagnose it and not treatable, you shouldn't have premium IOL of this patient. Otherwise, they will be unhappy and you cannot solve it at all.
Yeah, very, very important. As even you know that once upon a time, around 10 to 15 years before India, we never used to bother about the premium lens. But now the increase in this premium patient, now everybody wants it off. Everybody wants to go with trifocals. So I think these investigations are very important for a final outcome.
Thank you very much for all. Now we can move to Dr. Osama Shalabi, and he will give a talk about optimization of ocular surface before refractive surgery.
It's other way around, I think.
So,
It's
Osama,
anyway.
ready.
That's is my talk. I'll do that, and then so the impact of so I'll share mine. This will be talking about the impact of refractive surgery in ocular surface disease.
I will do the ocular cataract.
The impact of refractive
Shalabi
surgery. Then
cataract.
Dr. Mohammed Osama will talk. I'm not sure is that my screen shared now?
Yes.
So basically, I'm just going to talk about the impact of refractive surgery on ocular surface, which is continuation with the previous talks with my colleagues. As we discussed earlier about dry eye is like a vicious cycle, but one of the important factor which us as a doctor creating is the refractive surgery, and that's another factor which creating dry eye. Dry eye is very common complaint and frequent after a patient have laser vision correction, and many of them dissatisfied with the result because of that. So postoperative dry eye also predisposing to potential vision threatening problem, flap wrinkles, displacement, refractive regression, but also can predispose this patient to microbial keratitis. So detailed preoperative screening optimize the ocular surface prior refractive surgery is the key to minimize the incidence and severity of the postoperative dry eye. If you don't treat dry eye before, you will have more difficult to treat it after the laser surgery, but also the same things apply for the cataract surgery. The etiology why people get the dry after corneal refractive surgery is multifactorial. The most important mechanism really transition for the corneal nerve sensation, so that will reduce the blinking and reduce the natural tear production reflex, and that will cause reduced tear secretion and increased tear instability. This disruption of what you call neurotrophic factor, which is released by corneal nerve to promote the growth of the cornea, and also cause postoperative inflammation associated with the trauma and wound healing, that creating inflammation that also predisposing to the dry eye. Reduce the blinking because the sensation become less, so the patient become less blinking, and that's also reducing what you call the meibomian gland function. There's also direct trauma to conjunctiva with the suction, especially with LASIK or SMILE, when you squeeze in the conjunctiva with the suctioning, especially with the older one where you stay suction longer. Now, thank goodness that the femtolaser all is much faster and SMILE is much faster, so the suction is short, it become much lesser, so less damage to the goblet cell and the conjunctiva. The degree of corneal damage variable depends on the procedure, and that's why Dr. Mahmoud talking about different procedure, BRK, SMILE, and the LASIK and femtolasic. Everyone had different effect in the incidence of dry eye. The change in the other things with after refractive surgery, remember that we changed the cornea curvature. So especially with hyperopia, we make the cornea more curved. So that's the tear become unstable more. Also, if you make the cornea too flat, that also become unstable, the tear film in the cornea. And so that's changing curvature is another factor. Also, when we do the surgery, we may use a lot of medication, and that's the preservative especially, that can be toxic to the ocular surface and the conjunctiva. The incidence of dry eye post LASIK, for example, is ranging from 36 to 75%, but really almost every patient, I will tell every patient after laser surgery or any refractive surgery, all the patient will get some degree of dry eye disease immediately after surgery. But the good things, majority of them, they recover. The pre-existing dry eye before surgery, the most risk factor why people develop dry eye after laser surgery. More risk increase if you do deep ablation. Remember, the more deep ablation you damage more of the nerve sensation. If you do hyperopic ablation, because you go deeper in the periphery, so you cut more of the nerve and damage more. If you had a large LASIK flap, you go into creating more dry eye, a thicker flap. And before, people talking about, is it nasal hinge better for dry eye? That nowadays, with the better understanding and better imaging of the nerve fibers, the hinge position, they said, is not as important as used to be. But femtosecond laser, because we're creating a thinner flap, so we less damage to the nerve. Also, we're creating smaller flap, and there's not the flap, the cut is linear. That will reduce the damage to the anterior stroma nerve and indirectly reducing the risk of dry eye. There's another modality to neurotrophic ocular pain. Patient complain of persistent, some patients after laser surgery, they may come to you complain persistent and disability ocular pain, and maybe also the hyperalgesia, allodynia, which the sensation of the cornea become very poor. They have multifactorial reason, but they are very common. They have correlation. People, you examine the patient, they don't have much sign, but they have too much symptoms. So there's no consistency between the symptom and sign, and that will affecting the patient. Almost one patient in 900 patients underwent LASIK. They developed this what you call corneal neuralgia, and it's very good way to using anesthetic drops to help you differentiate this patient who they have a central sensation poor, compared to differentiate between central and peripheral nerve origin for ocular neurogenic pain. And really, we used to be ignored this patient who's coming after laser surgery complaining of severe pain, even with small wind, they complain of pain. And when you examine them, you find nothing, and we tend to ignore them before, most of us. And nowadays, we look after them more, and we are involved in their management much more than used to be. This is a confocal look into the effect of LASIK and SMILE. As you know, SMILE preserve more nerve, but still, if you look into after 1 week, also in SMILE, you damage some of the nerve, but the recovery of the nerve faster in SMILE than femtosecond laser. But after 6 months, you see the nerve growth is very good. And most of the studies show now, after a year, really, the SMILE, LASIK, the nerve regeneration is very close. BRK is less damage to the nerve, as we know, than the LASIK and the BRK and SMILE. Sorry. There's another disease they call laser-induced neuropathy. It was described first by Wilson. It's a dry-like symptom condition, patient with they have epithelium erosion after laser vision correction, and that cause pain, discomfort. Usually, it happens the first few days to a few weeks after laser vision correction. It's really related to reduced supply of neurotrophic factor to the epithelium cell, so that's reducing the tear production and reduce the blinking. And the majority of people, it's resolved within the first 6 months. Regarding when you see the patient after laser vision correction assessment, we do all the ocular surfaces staining, which I think the staining is very crucial because you can see the staining, but also that will measure the tear breakup time. You could use the machines nowadays. Also, you can use non-invasive breakup time, Sherman test, tear meniscus height. All these tests, the standard, will help assess people who had laser surgery to assess their dry eye, but you could use more fancy advanced machine, mammography, tear film inframeter, tear analysis, inflammatory marker measurement. One thing is really for this patient who complain of neuralgic pain, the confocal microscopy is a very useful tool to diagnose this patient, because when you see with the confocal, that you can diagnose neuralgia of this patient, and that will help you to do the right treatment for this patient. So preoperative, when you do before laser vision correction, it's very important to identify patient with pre-existing dry eye disease and treat it according. and you have to choose, maybe they change the procedure type for this patient. So sometimes may go for BRK instead of LASIK if someone had dry eye. But remember, if the patient had moderate dry eye and you treat it and doesn't respond well, or you need to have maximum treatment, and then you need to always, what I do really, if I treat patient with dry eye, I always try to improve it, but after that, try to reduce the lubricant to like 4 times a day, stop this all other anti-inflammatory. Make sure that this dry eye is mild and controllable with the artificial tear before I do surgery. Otherwise, if it's not controllable with artificial tear alone, I prefer not to touch them with any refractive surgery. Regarding the various treatment, we can use it, and usually using what we could call step ladder approach. Usually most of us use lubricant, which is the main treatment, but we can use anti-inflammatory drops, steroids, cyclosporine, Zedra, azithromycin. Punctum blocks is very useful for people after laser surgery to promote the recovery, and usually even you can use dissolvable one. Autologous serum, I use it for people who has not settling well, especially for like BRK, where the epithelium healing is very poor. That also promote epithelium healing. Amniotic membrane can be very useful. That is very useful for patient also post LASIK neuralgia. This is the picture of one of my patients. This is what to call it Bruchera Slim Clear, which is basically one advantage of this Bruchera Clear. The center, there's a hole, so the patient can see through the hole. So it's not like the normal Bruchera where the vision become blurry. So that's just give it growth factor and the nutrition while you keep the patient happy with the vision. So conclusion, post-operative dry eye has high prevalence among post-corneal refractive procedure and can significantly really impact the quality of vision and the life of this patient. Remember, you hear about stories, some people even commit suicide after laser. One of them is, I remember a few years ago, in America, TV presented, she committed suicide after smile procedure because of that bad dry eye. So very important to treat the patient and preoperative assessment to avoid any severity, and you need to look after this patient. Severity and duration of the disease, it can be variable. It really it's had too many factors. One of them really the surgical procedure. Which surgical procedure you do? You know, the LASIK is worse than film to LASIK, is worse than smile, is worse than, so there's every procedure they have risk of dry eye slightly more. Make sure that pre-existing dry eye need to be controlled and mild. And if someone had very high refractive error, that's risk of dry is more. Proper preoperative evaluation and counseling can help detecting high risk patient and minimize the post-operative dissatisfaction. Management the post-operative refractive dry eye, it's you need to act in different way and be prepared to use all different modality, including anti-inflammatory, plug, serum, Bruchera, amniotic membrane is all. You need to treat it well, and sometimes you need to have different way to treat it. Most cases, thank goodness that really most of the cases dry eye resolved within 1 year. However, small minority of the patient, they can progress to chronic dry eye, or also some of them rare, they may go for corneal neuralgia, and there this patient need more aggressive therapy and longer treatment. And thank you very much.
Thank you very much, Sama. Really very nice presentation. So we are going systematically in all our presentation. Is there any comment or question to Dr. Osama from the panel?
Very nice presentation as usual, Dr. Osama. And I really appreciate you have emphasized on amniotic membrane. We are trying now in Egypt to produce amniotic membrane eye drops. Actually, till now, it's not efficient. I have tried several preparations, but I think, and I would like to know your opinion also and the opinion of the panel, I think growth factors are very important in such cases. And if we can get to have them purified and liquefied and has a vehicle and preservative free, and we can put them in the eyes of the patient.
I think, Dr. Mahmoud, we have prepared the amniotic membrane eye drop. We have
I
the
know, Osama.
MDCs,
Yes.
in the Faculty of
Dr.
Pharmacy
Osama,
lab. I think
but
they are processing very well.
it's not that efficient. I've tried them. There is in
Yes, it's not
the nuclear.
absolutely efficient. It has some
لا
cases. Maybe
يعني مش it's not
it's not the sole
it's not
agent.
what,
Yeah, it's not the maybe
yeah,
adjuvant
the problem
or
is
some.
you have three for any drug يا دكتور أسامة شلبي, any drug basically as we can speak, you need a vehicle, a preservative, or you have it in monodoses not to be a preservative, and penetration. So if the three things are not there, if equally and efficiently, the drug you are using is actually nothing. So Dr. Samih Sharbagi, I know that his son had the thesis and it was very efficient thesis, but I think,
Ethics.
yeah, I think, Osama, the way you have to separate the gross factors, not the crude way that they used actually.
Actually, the secret of the membrane lies in the stroma.
The stroma itself.
So degrading the stroma and emulsifying it and make it as a drop has no contact time on the ocular surface. The
Yes,
secret of ambient membrane effect is to be adherent to the ocular surface, to allow the growth factors and to penetrate and to integrate in the ocular surface.
inside.
The
But
drop,
you,
I agree with you with this point, as
can
the
you,
drop has very short contact time with the ocular surface. So
that's
it
the
is may
problem.
act as adjuvant to other lines of therapy.
Yes. Can
And
you have do you have the courage to put an amniotic membrane on a post-LASIK dry eye surface patient? You cannot. You need an eye drop.
never. The patient
The clear
will
one, I
not.
like it really, by the way. The clear, this one, that's why I said the picture of that. This is Bruchera clear, which is you can do it even amniotic membrane, make a hole in it, so the patient can see. Would
Yes,
still
it's
they had the membrane. So that's where really, because to blur the vision, he cannot function.
no, of
So
course
this
not.
clear one really is a good, they have like, I think it's 4 millimeter or 5 clear. And then at least you had still the membrane to give some nutrition factors, while still you don't obstructing the vision.
But
Dr.
Dr.
Osama
Osama
has
gave
many
you,
facilities in his
yes.
practice. The Brokera, it is not available.
No, but
We
you
have,
can use you
we
can use
have,
بلاش
amniotic
قر بلاش
membrane.
I have a
بلاش قر
Broker,
عليه بقى.
I have
No,
a
no,
Brokera substitute, Dr. Mahmoud. I have a Broker.
but you can use the amniotic membrane to find it bigger and smaller,
Yes.
and you had the disc really.
You have to
I
yeah,
have the modification of the Brokera made by
Yeah.
myself. I have a
yes.
conformer, a
Tell us about
conformer.
it, يا أسامة. Yes,
Yes,
tell us
the
about it.
conformer wrapped amniotic membrane, but it's not for refractive surgery patient. It may
It's
be for persistent epithelial defect, chemical burn, synecholysis, any great ocular surface problem.
yes,
I use a conformer wrapped with amniotic membrane. It acts exactly like the Brokera with no money.
with no money. One placenta, it gives gross membrane to 3,000 patients. One placenta. And now we in Egypt, we are gaining 2 million inhabitants per year.
Very,
Denmark
we
is
can
2
solve
million.
the problem, ocular surface problem in the world.
Yeah, we are increasing 2 million per year. You imagine? So one placenta for 3,000 patients.
About India. They have
I
less
don't,
than
I cannot speak. My friend here will say it. Gurgesh will tell you.
Okay, so we can move to the last but not least talk with Dr. Osama Sharabi, and he will give the impact of cataract on ocular surface disease. Then we can go back and discuss the question and the other the final. So we can finalize in around the normal time.
Okay, it is now shared.
Yes, please, Mr. Osama. You can
Yes.
make it. Yes, now excellent.
Okay. Thank you very much. I have it's a great honor for me to join this distinguished group of surgeons and investigators. Dr. Ahmed Ghanim apologized and tell me 3 hours ago to go for this title. So I stick to the title he gave it to me, I couldn't change, so I prepared it for this couple of hours. But I
No
think
problem, Dr. Osama.
every
Everything it will be nice, as usual from your side.
inshallah, inshallah. I think this time and this webinar, the great thing is it is we are disseminating the concept of ocular surface. First, the people doing surgeon doing refractive surgery, cataract surgery, they are doing it in like in islands, working in islands. So in the disseminating the concept, you are dealing with an integrated anatomical and functional unit controlled by neuroanatomical and hydrodynamic control is a very good idea. The impact of cataract surgery on the ocular surface, I think, is like the impact of keratorefractive surgery or any surgery over the ocular surface. Main point have been discussed by our distinguished colleagues in previous talks, but I think this may be a conclusion. Uh, Really, the ocular surface is affected by cataract surgery or affected by it. Yeah, the effect is interchangeable. Ocular surface disease can affect the result, and the cataract surgery by itself can affect the health of the ocular surface. So understanding this relation, it may be a compromise or an interaction. If two things are added to each other, a compromise result may get fine, friendly, or good result. But if interaction occur, will result into a disastrous effect. So if the cataract surgery is harmful to the ocular surface or not. First thing we have to consider in every unhappy patient after cataract surgery, you must search for unrecognized or untreated ocular surface problem of this patient. This is a very important message from this talk. The incidence of cataract, dry eye disease and cataract surgery meta-analysis yielded 37.4. In some studies, higher percentage have been documented. So about nearly half of the patients of cataract surgery have ocular surface disease problem. How can cataract surgery affect the ocular surface? We have in any operative procedure, pre-operative issue, operative technique by itself, and the post-operative course can affect. Pre-operative issue, most cases of present undiagnosed ocular surface disorders not diagnosed by the surgeon and proceeded for cataract surgery. Other part, preoperative medications as a preparatory effect for the cataract antibiotic, nonsteroidal, anti-inflammatory, anesthetic use just before surgery. All these are toxic to the epithelium. Point to the audience, toxic effect from the preservative has two factors, accumulative effect and dose-dependent effect. Accumulative effect means if I were using multiple eye drops, three eye drops, three types of medication are larger than one drop. And the dose dependent also frequent installation 5 times resultant effect if I use three eye drops 5 times daily. So I am collecting 15 times of preservative over the ocular surface. Operative techniques by itself is native for the cataract surgery from speculum insertion. Tight speculum may damage the meibomian gland, may stretch the levator aponeurosis, resulting in post-operative ptosis even. The incision location and the size and the position and the size of the incision also affects the incision. Irrigating fluid during the cataract during the procedure itself. Microscope light, high microscope, even the phacoemulsification technique by self using power modulation also are these hazardous effect on the ocular surface. Also the duration of surgery larger duration. Post-operative course, we have we face surgically induced ocular inflammation. I think Dr. Osama have discussed the role of inflammation of ocular surface, damage meibomian gland, and the toxic medication of the post-operative period. And this is the most phased problem in cataract surgery, especially. Most patients have multiple treatment. We face this in our everyday. What is the result? What is the effect of this? First time, tear film instability. I think tear film instability proceed by non-invasive breakup time. Always, I think the dry eye analysis machines are now widely distributed in everywhere. It gives a comprehensive analysis of the tear film, starting from measuring tear meniscus height, as we see here by the non-invasive breakup time and the invasive breakup time after installation of fluorescein. Also, it gives, if we shift it to tear film volume alteration, also from the peer-reviewed studies and the evidence-based medicine, reduced the Sherman test value and the lower tear meniscus height have been reduced also. Ocular surface inflammation is a very important point. I think this is the issue today of dry eye and inflammation. Which come first, the chicken or the hen? The inflammation causes dryness, and the dryness causes inflammation. This relation always connected with each other. You have to start the starting point, the dry eye. What you have to stop this vicious circle, inflammation, dryness, vicious circle. We know the presence of inflammatory mediators, increased activity of NMB, especially NBB9, they are responsible for many alterations of the ocular surface in the ocular. The cutting of the and the reduction of the nerves with this sign or this action having in destruction of corneal nerve was always related in general mind by LASIK, not in cataract surgery. Cataract surgery 2.8 millimeter or 3 or whatever, but also there is studies reduced the reduction in subbasal nerve plexus after uneventful cataract surgery. Chronic ocular surface pain, as Dr. Osama said, may lead patient to depression and even suicidal from this process. Risk factors for this increasing by even by age and sex, as elder age have more and computer use are more susceptible to have problems. Even
دكتور أسامة أنا مش سامعك.
like antihistaminic, antihypertensive, anxiolytic, antidepressant. All clear now? Antihistaminics, anxiolytics, antidepressant, all these cause a reduction in the tear film. Tear film secretion. Okay. Pre-existing dry eye disease is very important to study correlation between pre-existing dry eye disease and dry eye disease after cataract surgery. There is exaggeration of pre-existing dry eye disease have been exaggerated after cataract surgery. This presented by short film breakup time, higher corneal fluorescein. We have, as our colleague had shown, mammalian gland aggravation, mammalian gland destruction, and alteration of the tear film by abnormal meibomian in the tear film. The surgical technique itself also affects the result of surgery. Even the addition of film to laser assisted cataract surgery increase the risk of surgery by increasing the duration of surgery and the added effect of the suction ring, the corneal on the conjunctival limbal stem cells and destruction of goblet cells of the conjunctiva. So I think every step is hazardous by its native character. The severity peak of duration dry eye disease after cataract surgery start very early, and even from the first week start its peak from the first week and may persist up to 1 year after surgery. So we are doing uneventful surgery, but every step you must consider you are doing a hazardous effect over the ocular surface. What are the consequences of this motion? You have the most important unsatisfactory posterior outcome. Patient is not comfortable at all in every symptom. Second thing, new persistent ocular surface disease signs or exaggeration of the previous signs would be exaggerated or appearance of another signs. reduce the vision quality, alteration of the tear film. We know all that the precorneal tear film is considered an anatomical layer of the cornea. It is the first refractive interface. So any alteration will be reflected. You are doing very much surgery, implanted premium IOL, but you have very bad tear film quality. So the net result would be bad retinal quality. So it is a great problem. So always have in mind that you are dealing with an integrated multifunctional system with integrated neuroanatomical and hydrodynamic control. Any damage of any part of the reflex arc may result in a hazardous outcome. So don't rush for surgery. The patient will not escape. But give some time, brief delay even until you're completely confident that you are dealing with a perfect condition of the ocular surface. Don't proceed for the surgery. We have any doubt of any problem from the lid margin to the cornea, the tear film. Every component of the tear film must be perfect before you proceed for surgery. During the surgery, perform surgery, reduce the light, short surgery duration, adequate irrigation, soft manipulation, and use of OVDs frequently, even to cover the ocular surface during the surgery. I know that this is so we are in a bad situation. Everyone use very minimal amount of consumable during the surgery, not to open multiple OVDs for the saving effect. Lastly, careful post-operative evaluation. As the pre-operative evaluation, my colleagues have been discussed to discover any component, any defective component, and deal it with properly in the proper way. This is the last message, and thank you very much for this very short presentation. I have the message has been arrived. Thank you, Dr. Amri. Thank you, Dr. Osama. Thank you, Dr. Krish, Dr. Mahmoud Ismail, and thank you all.
Thank you very much for you, Dr. Osama. Really very interesting and very nice and well organized. You tell me within 3 hours you make this presentation. It is very beautiful one. And really it's, I don't anticipate actually, even if you prepared before all this kind of information that I'm going to see or listen to it. Really, I learned a lot from this meeting actually. If there is one message, before I know conclusion, but I think before I forget, we are actually not doing all this, what we are listening to. Most of us just bring the patient, IOL calculation, put the patient inside and go for surgery. I think the majority is, especially in the cataract. I will not talk about refractive disc. I will keep it for the refractive people. But really, this is what is going on in the majority of the, who is dealing with cataract surgery everywhere. So I think we need to change our way of dealing with the patient. And sometimes you can find one patient after the surgery, you measure he is 6'6", but he is not happy. I think is quality of this is very important, and why you are 6 and 6, one completely, why you are not. But really, if you think about it, it is really a quality. It's not available, that maybe he is suffering of something that we are not taking care, either pre-op or during the surgery or post-op. I will keep the comment for any of other colleagues, Dr. Mahmoud, Krishna, or Osama, and then you can go to the questions.
Yeah, I just wanted to ask one question to Dr. Osama. In one of your slide, you are showing about the amount of post-op nerve damage, which is high in SMILE than the femtolasic. What you really contemplating on this?
Sorry, what do you mean? Sorry?
One of your slides shows that
No, I
amount of
think
nerve
the
damage in the confocal microscopy shows that the amount of nerve damage is in SMILE more than the
No, it's
LASIK.
less. No, it's less.
Yes.
No, it's less.
Less, yeah.
No,
It's
it's less
less,
in the
not more.
slide. It's less.
Yeah.
But the recovery after 6 months, the recovery is the catching up, and people did another study over a year. After years, very close to each other.
Yeah.
After 1 year, actually, they all are almost the same, but
All
still
same.
we are Oh, yeah, but still the PRK gets to 100% at 1 year. None of the others, they catch the 100, at least in our study. I don't know in other studies, but it was very clear that it took 1 year to stabilize the eye once again as before. During this year, you have you were able to control your patient, and the patient does not go from one doctor to another seeking help. And actually, nobody cares for a post LASIK patient who was done with another surgeon. Go and the patient gets disoriented. If you control the patient psychologically and socially with you, actually, this is the secret, because once the 1 year catch, when you catch 1 year, actually everything is the same.
Yeah, one question to Professor Mohammed Ismail. Sir, like I just see, we started with PRK, then we went on to do customized, then LASIK, customize, wavefront, femto LASIK, smile. Again, we are going back to PRK. That is the one
Yeah.
scenario. Okay. But there is a one different thought of refractive surgeon thinking that the coming days is going to be the only lenticule model. I think our dear friend kept one of the conference in Bangalore, my friend Roy Shetty. He speak always said, okay, let us have a only lenticule base, because see, when Smile started under Visumax, now J&J comes with Silk, then Swind comes with the
With
Atos, and Zimmer comes with the Z8. There are four different machines now already have got a lenticule platform.
yes.
So, as we all know that, as most of our all speakers, including Dr. Osama, all agree that for up till -6 diopter, still you say that after 1 year PRK is going to be the ultimate. But again, to tell that, I'm really confused that this lenticule concept is going to be stay back, or still in the end we may land in only PRK?
I I think, well, let us be more, yani, you have discussed and exposed the situation very clear. Now, should we sacrifice the Bowman membrane and apply mitomycin, or just extract some kind of part of the stroma, of the anterior stroma, and keep the Bowman membrane? We all know that the Bowman membrane is the skeleton of the cornea. However, it does really function, the cornea, however, does really function well without the membrane. Thousands of patients and millions of patients, I presume it's now millions of patients, have undergone PRK, especially in the United Kingdom and Canada and Australia. These three countries, they are more prone to PRK than LASIK and filtration. I think, Dr. Krishna, that the technology of SMILE is not evaluated, not yet. It still has a lot of to go, and I think it will be the future someday. And I think, Dr. Osama, we have discussed. You remember, Osama Jalabi, a number of years ago, there was a Phoenix eczema laser, and it used to evaporate the stroma, focusing in the slit lamp delivery system to focus on the stroma and
Yeah,
to
yeah.
make change. Unfortunately, it was not a good idea because there was no slit to evaporate the gases outside. That's the trick of it. So there was a direct opacification of the corneas, and this Phoenix company have disappeared. I think one day, I think you just do a small incision, and you don't extract the lenticule. You do intrastromal ablation, not extraction. You understand what I mean? I
Yeah,
think
but
so. I think we presume, not in our days, definitely not in my days, because this will take a lot of things. Because the companies, they have to get a
Disclose
lot
the
of
whole
money, a lot
at
of
some
money
time.
from their invention, and they are not satisfied yet with the money they're getting from the SMILE technology. So they won't investigate in another way. I think so, Dr. Krishna. I don't have any information, but I'm thinking Yani, that's what we have seen before, actually. They don't get a drug except when they have finished all the possibility or potential of such a drug.
No, you are right. Actually, see, about the lenticule concept also, even though there are 4 companies already have come with the lenticule problem, but a lot of my friends keep calling. Someone might be having a Z8 from Zimmer. Today, only one doctor called me and told, because I do a lot of smile training. I have trained more than 150 to 200 doctors in and around the world for a smile. So they keep calling me and telling that they did a Zimmer treatment, but they did it like a sort of a clear smile, then the whole flap is out, it seems. So all this kind of, if you ask me, I think still, as far as the lenticule is concerned, still Visumax scores the highest mark in comparison with any of this technology. These people are trying to copy lenticule, still they are not up to their mark when you compare with the Visumax, because Visumax 500 is there for last 10 to 12 years. Then they launched Visumax 800.
Yes.
Of course, I don't have any financial interest as far as the Visumax is concerned. I'm just what we
We are
evaluate.
thinking together, yes, yes. But
Yeah.
I also, let us be honest together.
Mm.
A untrained cataract surgeon can do LASIK.
Yeah.
Untrained cataract surgery cannot do smile, because smile is a surgery,
Yeah.
needs a surgeon.
Yeah.
So my advice to people who would like to master the smile, they should be a good anterior segment, at least good anterior segment surgeon, to manage the complication. And we are not speaking about straightforward cases, because straightforward cases will go on and on and on. But for a PRK, you don't need to be mastering the anterior segment surgery. That's, I think, the difference. I don't know what's the opinion
Yeah,
of
you
the...
are right. Because since I trained a lot of doctors, if you ask in my library, almost every complications of smile. But I don't show because most of the time Zeiss people come and fight with me. If you show most of these complications, nobody will buy my equipment. There is a, but again, while learning, it has got a definitely big learning curve. I do agree with you.
Also, you yourself said, I am training smile. Okay.
Yeah.
Is anywhere in the world somebody's training PRK? No.
No, nobody.
But training smiles, yes, you need training smiles.
Yeah.
So
Yeah.
that's very obvious.
Yeah.
Dr. Amri Basha, I think we conclude and we answer the questions of the colleagues, because I think they are waiting for
Yes,
their...
because there is a lot of time. We are already behind the time, but we are enjoying the discussions myself.
okay, we have time. Okay, I'm sorry, I don't
No
want
problem.
to...
The time is for you.
With the
We are
conversation with
open.
Dr. Krishna, it's endless. He has a
Yeah,
very
this-
good points, actually. And
Usama,
we
can you
have to...
take that, because I cannot open the question from my side. If you can open it from your side and ask, I was trying to solve it.
Okay, so one of them is the question about punctum plugs. Do you think
Okay.
that punctum plugs induce more harm if they close the drainage of inflammatory mediator after surgery? Usually it depends. If after laser surgery or cataract, usually it's not the meibomian gland dysfunction is the problem. Usually it's the aqueous secretion and reduced blinking. So usually plugs will help in these cases, not like the people who has just meibomian gland dysfunction and bad inflammation. But usually, you need anyone with dry eye with a sign of clear inflammation, you need to use anti-inflammatory, reduce the inflammation, then use the punctum plugs.
Okay, Usama, if you can go very fast for those questions, important, only the important questions.
One question about doxycycline absorption affected by milk. Yeah, we know that is affected, so you need to have a gap between drinking milk and doxycycline. But as we mentioned earlier, now we shifted to use azithromycin much more. People had zebra, they complain of redness and stinging. How to encourage? Usually, once explain to the patient, you're going to feel irritation, redness, discomfort initially, but once you control the dry symptom improve, that this patient compliance is much better, because you told him. Well, like anything, even before laser surgery, you've told the patient you're going to have dry eye, you have maybe night vision, halo glare, and that will settle when we can manage. That once the patient expectation, you told him before any surgery, he understand it and you know that's temporary time and that will settle. So that's another question, but I don't see anything other than this is a question really in my side.
That's I mean we have done. Okay. Thank you very much, Usama. You solved the last questions. So I would like to, at the end, to thank you all. Really appreciate your time and your expertise and giving this chance to learn from all of you. Thank you, Dr. Mahmoud. Thank you, Dr. Usama, Dr. Krishna. And thanks
Yeah,
for all
before that,
our...
I just want to tell one word. I want to share with everybody, when I came to Dubai 20 days before, the level of hospitality by my brother, Dr. Mohammed Ameri, was amazing. You treated me so well, so kind of you. We'll all invite you for our All India Ophthalmology Conference, which is going to held the next year. Definitely we'll call everybody. I think most of the persons might have come to our place. Definitely we're going to invite you most of our conferences.
It's nothing to mention, my dear Krishna, nothing but have done. Thanks a lot for this nice
Same here, Dr. Krishna. Dr. Amri is a very, very generous host, and we enjoyed with him the last MIOM meeting, and he's very generous to all his guests. Thank you very much for
learn
this.
from you, Dr. Mahmoud. You are the first. You are very generous with us also. Thank you, Dr. Osama Sharabi. It's nice to see you. And also, I would like to announce that we are going to have the next meeting. It will be on the 2nd of March. So we will be there, inshallah, with all. At the end, thank you for all. Thank you also for the Boshan Lom for sponsoring this meeting. Thanks all. Thank you very much and good night. Assalamu alaikum.
Good night.
Thank you very much. Thank you.
Alaikum salam.
Good night, everyone. Thank you.
Assalamu alaikum.